next speaker, Sinéad Berry. Sinéad has a successful careers in magazine publishing and e-commerce before enrolling on the Personalised Nutrition MSc program at CNELM. Since graduating, Sinéad has had her work published in the Journal of Reproductive Immunology and now divides her time between clinical practice focusing on women's health, working as food editor for wellness brand Deliciously Ella, and being a mum. The published paper which Sinéad is talking about is titled Vitamin D Deficiency and Female Infertility, a Mechanism Review examining the role of vitamin D in ovulatory dysfunction as a symptom of polycystic ovary syndrome. Thank you very much, Sinéad.
So firstly, I'd like to say thank you to CNELM for inviting me here today. And as Michelle mentioned, my research was published earlier this year. So it was a systematic review examining the pathophysiological mechanisms of female infertility in PCOS, focusing on the role of vitamin D. The study population focused on infertile women with anovulatory PCOS, and mechanistic evidence from animal and in vitro studies was examined to identify the potential role of vitamin D deficiency. In terms of intervention, the efficacy of vitamin D supplementation to ameliorate ovulatory dysfunction was explored. And when considering potential mechanisms, it was hypothesized that vitamin D deficiency is associated with female infertility through impaired ovulatory function. And this is as a result of dysregulated follicle development and number of dominant follicles, hormone levels, including anti-Müllerian hormone and androgens in particular, and elevated oxidative stress as a result of an accumulation of pro-inflammatory AGEs and the formation of reactive oxygen species in ovarian tissue. The primary outcomes included improved folliculogenesis, hormone levels, menstrual cycle regularity, and ultimately pregnancy as a result of vitamin D supplementation. The aim of the literature review was to provide deeper insight into the pathophysiological mechanisms of female infertility in PCOS, focusing on the role of vitamin D. It aimed to critically evaluate the potential benefits of vitamin D supplementation on infertility mechanistic markers symptomatic of PCOS. The objectives were to determine the pathways that may associate vitamin D deficiency with impaired ovarian follicle development, to evaluate the effect of vitamin D deficiency or insufficiency on the production of reproductive hormones that are key to ovulatory function, to assess the relationship and interaction between AMH, vitamin D, granulosa cell proliferation and follicle selection, all of which potentially impact ovulatory function, to assess the impact of vitamin D deficiency on inflammation and oxidative stress on reproductive function, and finally to evaluate the efficacy of vitamin D in correcting ovulatory dysfunction in individuals with PCOS. In terms of broader context and how this adds value to the field, a deeper understanding of vitamin D mechanisms in reproductive function has the potential to inform a personalized approach to testing in diet, lifestyle, and supplementation for those individuals with anovulatory PCOS. With potential improvements to symptoms, fertility, and medical treatment outcomes, such as IVF. Infertility is currently such a widespread issue affecting 48.5 million couples, and one of the conditions known to impact female fertility is PCOS, which affects 4 to 20% of women of reproductive age worldwide, and it's associated with infertility in 30% of those seeking fertility treatment. Diagnosis of PCOS can be challenging as it has varying manifestations, but criteria in adult women is to have 2 of either irregular or absent menstruation, elevated androgens, or enlarged ovaries with at least 12 follicles. Menstrual cycle irregularity is observed in 85% of women with PCOS, with up to 95% experiencing some type of anovulation. And vitamin D deficiency is obviously also a modern phenomenon, with 1 billion people worldwide having inadequate levels. The presence of vitamin D receptors and vitamin D metabolizing enzymes in female reproductive tissue suggests that vitamin D has a possible reproductive function. A potential relationship between vitamin D deficiency and anovulatory infertility has been identified, where 70% of infertile women had vitamin D levels less than 20 nanograms per milliliter, and 91% had levels less than 30. So women with PCOS and vitamin D deficiency have also been found to have significantly diminished rates of ovulation, pregnancy, and reduced chance of live birth. And they also exhibit signs of chronic low-grade inflammation, characterized by elevated biomarkers, including CRP and TNF-alpha and IL-6. So as a result, the use of vitamin D supplementation as an anti-inflammatory therapeutic agent makes it a potential candidate for reducing anovulation. So 3 key themes came out of this research and potentially linked vitamin D deficiency with the pathophysiology of female infertility in PCOS, and they were specifically focused on abnormal folliculogenesis, hormone regulation, and oxidative stress parameters. So from examining the research, it became clear that the pathway of abnormal follicle development as a result of vitamin D deficiency is closely linked with the pathways relating to hormone dysregulation. So animal studies identified an association of vitamin D deficiency with altered hypothalamic pituitary ovarian axis function. Dysregulation of reproductive hormone balance occurred with vitamin D deficiency, where testosterone, LH, FSH, and the ratio between them becomes elevated, disrupting follicle development and leading to anovulation. The elevation of AMHR2 mRNA expression in granulosa cells of small follicles was shown to result in abnormal overproduction of AMH, and reduced granulosa cell sensitivity to FSH decreased aromatase mRNA expression and dysregulated estrogen production via AMHR2 inhibition of the FSH-induced adenyl cyclase activation pathway. This may result in abnormal follicular development, including increased follicular atresia or degeneration of follicles, reduced mature follicle numbers, out of which a dominant follicle would normally develop, and failure to select the dominant follicle necessary for ovulation, and the absence of the corpora lutea, which is formed post-ovulation and secretes estrogens and progesterone. In vitro and animal studies identified a negative effect of pro-inflammatory AGEs on steroidogenesis and ovulatory function. So elevated AGEs resulting from diminished serum RAGE action, which would neutralize the action of AGEs and may exert a protective role on the follicular environment, may result in increased AMHR2 mRNA expression. And serum RAGE concentration was found to be lower in PCOS cells, and vascular endothelial growth factor was higher compared to control. AGEs may also promote lysyl oxidase activity, leading to the cystic morphology that's observed in PCOS. An increased AGE level was correlated with hormone imbalance, including elevated testosterone, A4, and decreased estrogen and P4. So this diagram shows how all 3 areas link together, but it's worth noting that many of the animal studies used PCOS models to synthesize similar features of PCOS. And despite being useful for assessing hormonal and ovarian dysregulation from a mechanistic standpoint, by nature, the models can provide completely identical features to women with PCOS. And there were also some contradictions between studies. For example, in one in vitro study, found that follicle stimulating hormone receptor mRNA was significantly increased in vitamin D. However, another analysis determined there was an 18% decrease with vitamin D. And variances may be due to differences in species, but also potentially as a result of differences in the follicular maturity of cells examined, where FSHR is at its highest in immature follicles and gradually declines with maturation. So in the animal and in vitro mechanistic research, vitamin D supplementation was associated with positive outcomes in hormone regulation, successful follicle maturation, improved aromatase expression, and downregulation of ROS, whereby the proliferation of granulosa cell follicle growth was enhanced and FSH sensitivity increased, leading to improved follicle selection. In terms of human intervention studies, supplementation proved successful in delivering sufficient serum 25-hydroxyvitamin D concentration in deficient individuals. Overall, the human intervention research determined the potential hormone regulating and antioxidant capability of vitamin D, resulted in improved folliculogenesis, menstrual cycle regularity, and hyperandrogenism indicators. Vitamin D supplementation was linked to a reduction in AMH, and vitamin D deficient women with PCOS had significantly elevated AMH. But 50,000 IU once weekly for 8 weeks resulted in a significant decrease in AMH in those with PCOS. Improved endometrial thickness and reproductive environment, including increased occurrence of pregnancy, was demonstrated with a single dose of 300,000 IU vitamin D. And the anti-inflammatory therapeutic effect of vitamin D was linked consistently to consistently significant decreases in high sensitivity CRP, and a significant increase in SRAGE was demonstrated after 8 weeks of 50,000 IU supplementation. Co-supplementation interventions also showed promise, with a number of studies using vitamin D with other nutrients such as calcium, magnesium, evening primrose oil, and probiotics. And the results suggested a potentially synergistic effect that enhanced the anti-inflammatory benefit. Vitamin D, calcium, and metformin, which is a drug regularly prescribed for PCOS, produced a positive effect on follicle maturation, where growth was significantly higher compared with control, and menstrual pattern improved, although enhanced follicle response was shown to be non-significant. But large, high-quality intervention studies were sparse, and in these studies, the most significant results, the majority had sample group sizes of less than 30 people. So differing dosages and administration of vitamin D, along with the unidentified individual impact of specific nutrients in co-supplementation, suggest the need for larger RCTs to determine the validity of vitamin D supplementation. So overall, results from intervention research supported the findings from mechanistic studies regarding the potential hormone regulating and antioxidant capability of vitamin D. Although despite promising studies reporting pregnancy success, the efficacy of vitamin D as an intervention for reducing infertility as a symptom of PCOS couldn't be determined. High quality studies were limited, with the absence of pregnancy as an outcome. Measurement of vitamin D levels also varied between studies, with baseline serum either not documented or deficiency criteria differing, and dosage and duration also varied widely. Vitamin D deficient for vitamin D deficient adults, the Endocrine Society recommends supplementation of 50,000 IU a week for 8 weeks. And the beneficial impact of this dosage was supported by results from a number of the studies looked at in this review. But timing of vitamin D administration during the cycle should also be considered. IVF trials established that increased levels of 25-hydroxyvitamin D in follicular fluid may negatively affect oocyte development, leading to decreased fertilization rate. However, low serum vitamin D concentration was also linked with higher miscarriage rates, which potentially relates to the findings in this research, where sufficiency may contribute to the provision of a suitable reproductive environment. The progesterone-like activity of vitamin D during the luteal phase is also of interest. With structural and functional similarities, vitamin D and progesterone work synergistically to support the luteal phase onwards through immune modulating actions and inducing anti-inflammatory pathways. And progesterone has been found to reinforce the anti-inflammatory effect of vitamin D and vice versa between the luteal phase and 12th week of pregnancy. Low progesterone is also exhibited in women with PCOS. And during the follicular phase, estrogen promotes increased production of IL-6, which is suppressed by progesterone in the luteal phase. Therefore, insufficient progesterone may result in overstimulation of the immune system and the production of autoantibodies and potential reproductive failure. So consequently, vitamin D, with its immunomodulatory action and similarity with progesterone, may provide beneficial support during this phase of the cycle. The research didn't explore specific association of vitamin D with obesity and insulin resistance, which are associated with PCOS. Studies examining genetic factors were also excluded, but there were some papers examining the association of vitamin D receptor gene polymorphisms and female infertility. The research also highlighted the need for standardized criteria to create a more robust evidence base, such as for evaluating vitamin D adequacy and PCOS. A limitation of multi-supplement study design.
Sorry. I'll give you 1 more second, yeah.
Okay.
Thank you.
Almost done. A limitation of multi-supplement study design is the inability to determine whether effects come from vitamin D or the partnered nutrient. And further investigation into the potential enhancement of metformin and vitamin D may be of further interest for primary research. And there are other co-supplementations with myo-inositol and vitamin D, which were very promising. So despite limitations, the systematic review and analysis of the mechanisms linked vitamin D deficiency with ovulatory function, and it does offer insight into the pathways and demonstrates a potential role in female fertility and for further areas of investigation in clinical practice.